Alright, so starting from question number 101 of Infectious Medicine, Passmedicine, the question says a 24-year-old woman presents to their GP with a 4-day history of vaginal discharge and irritation. The discharge is minimal, clean, watery, and offensive, and she had no abnormal vaginal bleeding. She also reports some mild dysuria on sexual activity history. She reports having switched sexual partners 2 months back, shortly after she developed genital thrush, which was typically treated with topical clotrimazole. The only notable finding on vaginal examination was that her cervix bled easily when swabbed. Okay, so what will be the treatment of choice for the most likely diagnosis? As we can see here, that patient had genital thrush after having the switching of sexual partners, then it is a strong pointer towards the chlamydia, and we know that we treat chlamydia with doxycycline. Now let's read the explanation that the patient is displaying signs of symptoms of sexually transmitted infection, okay, chlamydia trachomatis, and it is most of the time it is asymptomatic in 70% of the women. And what are the common symptoms? Dysuria, vaginal discharge, and abnormal vaginal bleeding. A 7-day course of doxycycline is first line, and azithromycin is usually used in chlamydia trachomatis if the patient is pregnant or if doxycycline is contraindicated. Alright, so number 1 is doxycycline, first line, and number 2 is azithromycin if patient is pregnant, because doxycycline is contraindicated in pregnancy. This is another important MCQ point. Next is chlamydia is used in the treatment of clindamycin. Clindamycin is used in the treatment of bacterial vaginosis, and bacterial vaginosis is characterized by grey, thin white vaginal discharge having a fishy odor. It is not sexually transmitted and is associated with the use of recent antibiotics and as a thought of to alter the flora of vaginal gland. Alright, so oral fluconazole is the treatment of choice for vaginal candidiasis. Remember, for clindamycin is mainly for bacterial vaginosis. In bacterial vaginosis, remember that whenever it is bacteria, most of the time there is no itching. This is a differentiating point whenever it is bacterial infection of vagina. It is grey, thin white vaginal discharge, and most of the time whenever it is vaginal candidiasis, remember, candidiasis is thick discharge and white curd like proper, and bacterial is thin white grey discharge, and bacterial has fishy odor. Alright, and okay, and whenever it's candidiasis, we most of the time use azole, and in azole we use the azole drugs. Okay, we use the oral fluconazole. Next is metronidazole. Metronidazole is used to treat vaginal infections such as bacterial vaginosis and is not first line for chlamydia. Okay, so what is chlamydia? We are gonna study about the chlamydia. Chlamydia is the most prevalent sexually transmitted infection in the UK and is caused by chlamydia trachomatis, an obligate intracellular pathogen. Particularly, approximately 1 in 10 young women in the UK have chlamydia. The incubation period is around 7 to 21 days, although it should be remembered as a large percentage of cases are asymptomatic. Okay, so the features, what are the features? Number 1, dysuria. As we have already studied about that, the main feature is the dysuria, but how it can differ both in men and women. So whenever it's men, most of the time it is urethral discharge, okay, but in female there is also inflammation in cervix, so there might be a cervicitis, and plus there might be a bleeding. What can be the complications? Of course, if it is dysuria and the urethral discharge, it can cause epididymitis, inflammation of the epididymis, PID, because it is the pelvic inflammatory disease, and if the inflammation is in cervix, then it can also move upside and it can cause the inflammation of the pelvis region, which we known as the pelvic inflammatory disease. Next is endometritis, increased incidence of ectopic pregnancy, because we know that PID, pelvic inflammatory disease, because the infection which was in the urethra and after that it was moved to the vaginal, because it is at the because it is due to the sexually transmitted infection, it is moved towards the uterus and all of the fallopian tubes, the ovaries. So that's how it will cause the pelvic inflammatory syndrome, like, okay. and if there is a pelvic inflammatory syndrome, then there will be high incidence of ectopic pregnancy, and if there is ectopic pregnancy incidence, automatically it will cause infertility, because it definitely decreases the chances of getting proper pregnancy and the proper implantation. Okay, next is reactive arthritis, and next is perihepatitis. Okay, so here is the Fitz-Hugh-Curtis syndrome. Let me tell you a mnemonic how you can remember the potential complications. Okay, so here I made the mnemonic for it, that how we can remember. Number 1, the female genital tract. Number 2, extragenital. Number 3 is neonatal. So how it can cause how we can remember them in a perfect way. Whenever it is pelvic inflammatory disease, okay, it can cause salpingitis, the tubal damage, and of course the tubal damage can cause the infertility and ectopic pregnancy. Now I hope that now it will make sense to you. Next is extragenital. Extragenital, how we can remember the extragenital? Reactive arthritis. Can't see, conjunctivitis, can't pee, urethritis, can't climb a tree, arthritis. All right. And next is neonatal, conjunctivitis and pneumonia. And you know that we have already read about the perihepatitis, which is Fitz-Hugh-Curtis syndrome. Next is investigations. Transitional cell culture is no longer used. Nucleic acid. Next is the nuclear acid amplification test, NAAT, NATs are now the investigation choice. So remember, whenever it is chlamydia, we will use NATs as the investigation of choice. And always remember that number 1 is urine test for men, because it was the urethral discharge in men, so we will end dysuria, so we will do the urine test in men. And whenever it's women, we will do the vulvovaginal discharge, because it is the dysuria and cervicitis. Chlamydia testing should be carried out 2 weeks after the possible exposure. All right, so after the exposure we have to do the chlamydia testing after the 2 weeks. This is another MCQ clincher. All right, and let's move ahead. Screening thing, okay, relies heavily on opportunistic testing. Pap smear demonstrating infected and endocervical cells. Red inclusion bodies are typical. Red inclusion bodies are typical of chlamydia. Next is management. So in management, we can see that doxycycline 7 is, as we've already read about it, this is now preferred to azithromycin due to concerns about Mycoplasma genitalium. This infection is often coexistent in patients with chlamydia, and there is evidence of rising levels of macrolide resistance. Alright, if doxycycline is contraindicated, then, and in which case doxycycline is contraindicated in pregnancy, alright, then we will give azithromycin 1 gram OD for 1 day and 500 mg OD for 2 days. And if pregnant, then what we will do? Azithromycin, erythromycin, and amoxicillin, or okay, AEA, azithromycin, erythromycin, and amoxicillin. The SIGN guidelines suggest azithromycin 1 gram stat is the drug of choice following discussion of the valence of and all the stuff. Okay, let me see, is there any other clincher point for the MCQ? Okay, so for women and asymptomatic men, all partners from the last 6 months, okay, or the most recent sexual partner should be contacted. Contacts of confirmed chlamydia cases should be offered treatment prior to the result of the investigations. All right, okay, so remember that from the last 6 months we have to check the partners, the women and the sexual partners. Okay, so the patient has come, he is having the dysuria, or a female is having dysuria. So in the previous 6 months, with whomever he or she has had a sexual contact, we have to do the testing on them also. Okay, let's move to the next question. Question number 102. I know that I'm taking a lot of time on each question, but as soon as we will move further, then it will become less difficult, because the concepts and the topics will be repeating, and we will be like moving easily. Okay, so next is question number 102. You're working in the emergency department and you see a 22-year-old man with an itchy erythematous rash across his back, shoulder and backs of his arms. The rash appeared yesterday after he started taking an antibiotic, having been unwell for 10 days with general malaise and sore throat. So remember, look at the clinchers. Number 1 here is the sore throat, general malaise. And always remember, whenever you are studying for any these kind of exams, first read about the last line, which antibiotic. So I know that what he's gonna ask me. Okay, so she erythematous rash on the back, so it's more like a rash kind of situation maybe. Okay, so rash, and rash appeared yesterday after he started taking an antibiotic. What it can be? Okay, we have to rule out that what it can be. The answer is amoxicillin. How amoxicillin? Because when there are upper respiratory tract symptoms plus amoxicillin and it is the rash, then we take it into the glandular fever. Why? Because patient is likely to be having infectious mononucleosis due to Epstein-Barr virus, okay, EBV, and amoxicillin is known to commonly produce a widespread erythematous rash in patients with infectious mononucleosis. For this reason, it should not be prescribed to patients with sore throats, okay, and penicillin is the first line choice for bacterial tonsillitis. So always remember, whenever there is a bacterial tonsillitis, like patient is having malaise and sore throat for a long time, like in this case it is 10 days, and the patient is taking antibiotic which is amoxicillin and cause the rash, so it is not good to be given this kind of antibiotic in those situations, because it might can cause an infection which we cause as infectious mononucleosis. Okay, so the patient's rash could be an articulated rash due to allergy of antibiotic, but there is nothing to guide you as to which antibiotic it is mostly allergic to. Infectious mononucleosis, remember, infectious mononucleosis known as glandular fever is caused by the Epstein-Barr virus, also known as HHV4 in 90% of cases. Less frequent causes include CMV and HHV, and it is most common in adolescents and young adults. So what is the classic triad? Remember, sore throat, number 2 fever, and number 3 lymphadenopathy in which areas? Anterior and posterior triangles of the neck. Okay, so other features include malaise, anorexia, headache, palatal petechiae. So there will be petechiae in the palate. Number 3 splenomegaly. Remember, lymphadenopathy, splenomegaly. Number 4 hepatitis, transient increase in ALT. Number 5 lymphocytosis, presence of 50% lymphocytes with at least 10% atypical lymphocytes. Hemolytic anemia, secondary to cold agglutinins, IgM, and a macular papular rash develops in around 99% of patients who take ampicillin, amoxicillin whilst they are having the infectious mononucleosis. Okay, so next is the how we symptoms will resolve in 2 to 4 weeks, and the diagnosis is made by heterophil antibody test, HAT, which is monospot test, and the NICE guidelines suggest full blood count and monospot is the second week of the illness to confirm the diagnosis of glandular fever. Okay, so monospot test should be done in the second week of illness. This is another MCQ point, important. Management is supportive and includes rest during the early stages, drink plenty of fluid, avoid alcohol, simple analgesia for any aches or pains, consensus guidance and all the stuff. That avoid playing contact sports for 4 weeks after having glandular fever to reduce the risk of splenic rupture. This is very important MCQ. Number 1 important MCQ was that upper respiratory tract infections plus amoxicillin can lead to glandular fever. Number 2 MCQ can come as HH4. Number 3 lymphadenopathy, which triangles, anterior and posterior triangles, both. Okay, and because in tonsillitis it is only the upper anterior, however in glandular is always the anterior and posterior both. Features: palatal petechiae, splenomegaly. As it is causing splenomegaly, that's why we always ask that don't play these kind of games that can cause the splenic rupture. Other things, hepatitis, of course, the liver inflammation, hepatitis, transient rise, but there is always transient rise. Palatal petechiae, splenomegaly, transient rise in ALT. Lymphocytosis, but at least 10%, like 50% lymphocytes, but at least 10% atypical lymphocytes. Hemolytic anemia, secondary to cold agglutinins. Okay, and remember the hat. Okay, hat, and they're in the second week. All right, let me check. Is there any important point being missing or not? Okay, so what I would love to study is the examiner pulse. So posterior cervical lymphadenopathy is the clue. Okay, because If it's only anterior, then it might be the tonsillitis only. And remember, because of ampicillin or amoxicillin, it is a rash, it is not allergy caused by Epstein-Barr virus. And avoid contact sports like risk of splenic rupture. And ultra fast recall line, which I love to make, okay. And it is young patient, sore throat, posterior nodes, fatigue, think Epstein-Barr virus, mononucleosis or infectious mononucleosis. Moving to the next question. Here we go again. Okay, question number 103. A 24-year-old medical student presents 3 weeks after returning from her 2-month elective in Malawi with a 3-day history of high-grade fever and rigors. She also complains of an itchy, raised rash, dysuria and tightness in her chest. She took doxycycline as malaria prophylaxis and is still completing the course. On examination, she has a fever of 38.9 degrees Celsius, a heart rate of 129 per minute, a widespread urticarial rash, and a scattered wheeze on auscultation. Examination of the abdomen reveals 4 cm hepatomegaly above the costal margin and 2 cm of the tip of the spleen palpable in the left upper quadrant. Urine is positive. Okay, I have told you now that we have to read the last line first. What is the most likely diagnosis? Moderate hepatomegaly. Okay, 4 cm below the costal margin. Now look at the numbers. Okay, HB is nearly normal, at the lower limit of normal. Platelets are normal, WBCs are high, neutrophils are also high. If neutrophils are high, it means acute inflammation or acute infection is going on. Lymphocytes are normal, monocytes are also normal, eosinophils are high, so allergic reaction might be going on. Sodium is normal, potassium is normal, urea is high, creatinine is very high, so kidney issues is there. Bilirubin 47 is high, and ALP is high. Okay, so what it can be? Katayama fever, which is a syndrome of acute schistosomal infection. Acute schistosomal infection can present with a syndrome known as Katayama fever. This woman is presenting with Katayama fever, an acute manifestation of acute schistosomiasis. The intermediate snail host of parasitic flatworm, which causes schistosomiasis, is found in the waters of Lake Malawi. Katayama fever typically presents with fever, urticarial rash, hepatosplenomegaly, and bronchospasm. Symptoms occur 4 to 6 weeks after infection and diagnosis clinical. So remember the features: fever, urticarial rash, hepatosplenomegaly, and bronchospasm. So bronchospasm is the main key factor in which by which we can differentiate it from the other stuff. So remember the hepatomegaly, splenomegaly, urticarial rash, fever, and bronchospasm. We are studying this together, and my main focus is that how we can remember each and every important MCQ point in a better way. Okay, so typhoid fever can present with hepatomegaly, fever, and rash. However, it is generally associated with a longer history of malaise, fever, and exhaustion, with gastrointestinal bleeding. In the later stages of disease, the rash would be described as rose spots. Okay, so Katayama, rose spots. Remember it by cutting the roses. Okay, Katayama fever, rose spots, red macules around the trunk. Bradycardia may be mentioned in a question regarding typhoid. However, typhoid generally causes leukopenia with a relative lymphocytosis and eosinopenia instead of eosinophilia. Okay, so it is the leukopenia, the less the WBCs will be low, and eosinopenia. The eosinophils will also be low in typhoid. Travelers may be recommended a typhoid vaccine prior to traveling to high risk areas including Malawi, but neither of the vaccines are 100% effective. Of course, dengue fever is a viral infection spread by mosquitoes, Aedes mosquitoes, we know about this. And the differentiating factor in dengue fever, always remember, there is a retroorbital pain along with abdominal pain, headache, fever, rash. There is a retroorbital pain behind eyes. Malaria is a parasitic infection, anopheles, we know about it, and causes fever, headaches, vomiting, diarrhea, and all this stuff. Kala-azar is visceral leishmaniasis, is the result of parasitic infection spread by sand flies. It presents with fever and hepatosplenomegaly, and most of the time it is related to travel. Next, schistosomiasis. So how we are going to study about schistosomiasis? Schistosomiasis or bilharzia is a parasitic flatworm infection. The three main species of schistosome are S. mansoni, S. japonicum, and S. hematobium. So what will be the acute infections? Acute symptoms typically only develop in people who travel to endemic areas, as they don't have any immunity to worms. All right, remember, as they don't have any immunity to worms. Acute manifestations: swimmers itch. Number 2, acute schistosomiasis syndrome, Katayama fever. We have already read about Katayama fever, and now remember it. I've told you, eosinophilia, okay, and relative lymphocytosis, plus there was also a rash, urticaria or angioedema. I've told about bronchospasm, okay? So bronchospasm, angioedema, fever, cough, diarrhea. So chronic features, these are the acute features, and this is the chronic features. In chronic features, schistosoma hematobium. So in hematobium, these worms deposit egg clusters which are known as pseudopapillomas in the bladder, causing inflammation. The calcification seen on X-ray is actually calcification of egg clusters, not the bladder itself. So always remember that whenever it is schistosoma hematobium and X-rays, you are seeing the calcifications. It's not the calcifications in the bladder. It's the calcification of egg clusters of pseudopapillomas, which are pseudopapillomas in the bladder, okay? And which organisms egg clusters are? Schistosoma hematobium. So they are actually calcification of egg clusters, not the bladder itself. Depending on the site of the pseudopapillomas in the bladder, they can cause an obstructive uropathy and kidney damage. Remember, obstructive uropathy and kidney damage. It is very important MCQ that schistosoma hematobium causes which kind of uropathy. It is obstructive uropathy, kidney damage of course, but MCQ comes in the form of obstructive damage. This typically presents as swimmer's itch in patients who have recently returned from Africa. Okay, swimmer's itch. Schistosoma hematobium is a risk factor of squamous cell bladder cancer. Of course, as it is, there are pseudopapillomas, calcification of egg clusters causing mutations, and it can act as a risk factor of squamous cell bladder cancer. It is another important MCQ feature regarding this. Next, frequency, there will be increase in frequency, there will be Manchurian bladder calcification. Again, this is another MCQ point. Investigations. For asymptomatic patient, serum schistosome antibodies are generally preferred. So if the patient is not having any symptoms like no fever, no urticaria, no angioedema, no bronchospasm, no arthralgia, myalgia, no cough, no diarrhea, no eosinophilia, no lymphocytosis. So we are suspecting it because the other person with whom he was traveling are having the swimmer's itch. We will check by serum schistosome antibodies, like through the blood. But for the symptomatic, it will be the urine or stool microscopy looking for eggs, okay? And what will be the management? Single dose of praziquantel. It's praziquantel, remember, single dose of praziquantel, single oral dose of praziquantel. Three things: single oral praziquantel. Okay. Schistosoma mansoni and Schistosoma japonicum. These worms mature in the liver and they travel through the portal system to inhabit the distal colon. Remember, from where they mature? Liver. Travel through portal system, of course, liver's portal system, to inhabit the distal colon. Their presence in the portal system can lead to progressive hepatomegaly and splenomegaly due to portal vein congestion, and these species can lead to complications of liver cirrhosis, okay, variceal disease, cor pulmonale. Okay, so how we can remember this? That at first worms mature in liver, okay, then they move towards the portal system, and then they inhabit to distal colon. So they are traveling a long journey. At first liver cirrhosis, then variceal disease, then cor pulmonale, and next intercalatum and Mekongii. What they will do, less prevalent, but are both attributed to intestinal schistosomiasis. So remember, whenever it is related to intestinal, intercalatum IN, okay, and Mekongii I at the last, I at the first. But don't mix it with Mansoni, please, because we have also most of the time we read about hematobium, Mansoni, japonicum, but these are very not very famous or less prevalent. Okay, I at the last, I at the start, I at the last. Intestinal schistosomiasis. Okay, next question. Question number 104. A 35-year-old homosexual man is referred to the local genitourinary clinic following the development of a solitary painless penile ulcer associated with painful inguinal lymphadenopathy. He has recently developed rectal pain and tenesmus. What is the most diagnosis? Okay, so remember what he is saying. Homosexual. It is very important. He is asking about diagnosis, but look at the buzzwords. So buzzwords are homosexual, solitary painless penile ulcer. Okay, solitary painless penile ulcer associated with painful inguinal lymphadenopathy, and now rectal pain and tenesmus. So what will be the diagnosis? Lymphogranuloma venereum. Many of the people feel that it might be syphilis, but why it is not syphilis? Why it is not syphilis? Syphilis is also painless. Syphilis is more common than lymphogranuloma venereum. Then why it is not syphilis? Okay, now we will move to it. Remember that genital ulcers, they are painful. Herpes and chancroid, and herpes are more common, and whenever it's painless, it is syphilis, which is more common than lymphogranuloma venereum. Because lymphogranuloma venereum has 3 stages. Now, 1, pustule ulcer. Okay, ulcer. Number 2, lymphadenopathy, and then proctocolitis. Okay, so let me tell you the proctocolitis at first. So now you can see that proctocolitis is the inflammation of the rectum and the lower part of the colon. All right, that's why as there is inflammation in the rectum and lower part of colon, it will automatically lead to tenesmus and rectal pain. All right, and both of them are pointing towards the lymphogranuloma venereum. Number 1, ulcer. Number 2, lymphadenopathy. Number 3, rectal pain and tenesmus, which is proctocolitis. Next is STI ulcers. Let me read it for you. Genital herpes is most often caused by herpes simplex type 2. Cold sores are usually due to the HSV1. Remember that the cold sores are most of the time near lips. All right, they are 1. Upper body 1, lower body genital region 2. Okay, that's how we can remember this. Primary attacks are often severe and associated with fever, whilst subsequent attacks are generally less severe and localized to one site. There is typically multiple painful ulcers. Syphilis, okay, remember, typically multiple painful ulcers. Now, why is not syphilis? Syphilis is a sexually transmitted infection caused by Aspergillus, Treponema pallidum. Infection is usually primary, secondary, and tertiary. A painless ulcer, which is chancre, is seen in the primary stage, and the incubation period is 9 to 90 days. Next is chancroid. Chancroid is a tropical disease, Haemophilus ducreyi, painful genital ulcer, okay, and associated with unilateral painful lymph node enlargement. All right. So remember, you can see that in all of them, genital ulcers, the syphilis ulcers, the chancroid ulcers, no body or no infection having the proctocolitis. Like you can see that in syphilis there is a painless ulcer, okay, as we have read previously. Painless ulcer is syphilis and lymphogranuloma venereum. So, but there is no proctocolitis. Chancroid, we have heard about chancroid and genital herpes, that both of them are painful. So how we will differentiate them? That most of the time they are associated with unilateral painful inguinal lymph node enlargement. Remember, Haemophilus ducreyi I1. Remember, it is one unilateral, one-sided inguinal lymph node enlargement. As chancroid is a painful genital ulcer, remember that the inguinal lymph node enlargement will also be painful. Next, lymphogranuloma venereum is caused by Chlamydia trachomatis. Typically, infections comprises of 3 stages, as I have told you before. Small painless pustule, which later forms an ulcer, stage 2. Painful inguinal lymphadenopathy and proctocolitis. LGV, lymphogranuloma, is treated using doxycycline. Okay, and other causes of genital ulcers: Behçet disease, okay, carcinoma, granuloma inguinale, and whenever it's granuloma inguinale, it is Klebsiella granulomatis, and previously called as Caelimobacterium granulomatis. Next question, question number 105. A 45-year-old man presents to the emergency department with cramping abdominal pain and bloody diarrhea. He is opening his bowel 6 times a day. He has no significant past medical history. He has mild generalized abdominal pain. So what it might be? Entamoeba histolytica, because we are thinking about amoebiasis. Why we are thinking about amoebiasis? Presence of dysentery after a long incubation period, like C. Trip after returning from trip 3 weeks ago, alright, after a long incubation period. Amoebiasis typically occurs 2 to 4 weeks after infection with Entamoeba histolytica, although can occur months to years later. It is a cause of dysentery, remember. Type of gastroenteritis that can cause bloody diarrhea, okay, bloody diarrhea. Campylobacter jejuni is incorrect because it is another cause of dysentery, but the incubation period is 2 to 4 days. So remember that camp, we only go, that there were girls who only go for camp 2 to 4 days, okay. And Entamoeba histolytica, as you can remember, is that there were men, men, and men are allowed to stay outside of their homes for a long time. So Entamoeba histolytica, it is only a mnemonic, okay. So they were after 2 to 4 weeks, and camp girls and 2 to 4 weeks rather than 3 weeks. Giardia lamblia. Why it is not? The incubation period of this infection is 3 to 40 days. So as we remember both of them by the mnemonic, so we have to remember this by our brain, that 3 to 40 days are used for incubation. So this could be consistent. However, it classically causes chronic intermittent explosive diarrhea without blood. So there is no bloody diarrhea in Giardia, alright. That's where it is ruling out, and that's where we are ruling out Giardia lamblia out of Entamoeba histolytica. Given there is no blood, it would not be classified as dysentery, and this is a wrong answer, of course. So Shigella dysentery, how it is? It will incubation period of dysentery is 1 to 3 days, okay. Shigella, she, at first it was camp, 2 to 3 girls, 2 to 4 days. She alone, she went there alone, 1 to 3 days. Rotavirus, we know rotavirus most of the time happen in the children, and it also 1 to 3 days. Amoebiasis is caused by Entamoeba histolytica. Entamoeba histolytica and amoeboid protozoan, and spread by the fecal oral route, okay. And E for fecal, O for oral, feco-oral route, alright. Profuse bloody diarrhea. There may be long incubation period, alright, up to 3 to 4 weeks, 2 to 4 weeks. Stool microscopy may show trophozoites if examined within 15 minutes or kept warm, known as hot stool, alright. So stool microscopy, trophozoite if examined within 15 minutes. Treatment, oral metronidazole. Number 2, luminal agent. Luminal agent to eliminate intraluminal cysts is recommended usually as well. For example, diloxonide furoate. So it is another important MCQ point. Number 1, fecal, important. Number 2, that amoebiasis can cause liver and colonic abscesses. Remember, A for amoebiasis, A for abscesses, liver and colonic, okay. Number 3 important point is profuse bloody diarrhea. Number 4, stool microscopy. Number 5, trophozoites. Number 6, if examined within 15 minutes or kept warm, which is hot stool. Number 7th important point, diloxonide furoate, okay. So next is amoebic liver abscess, usually a single mass in the right lobe, maybe multiple. The contents are often described as anchovy sauce, okay. Remember anchovy sauce, this is another MCQ point. Fever, right upper quadrant pain, remember right upper quadrant pain, hepatomegaly. Investigates ultrasound, and serology is positive in more than 95%. Again, management is the same. Oral metronidazole and luminal agent to eliminate intraluminal cyst. Remember, intraluminal cyst, not extraluminal, not extraintestinal, intraluminal cyst, okay. Diloxonide furoate. I will cover next 6 MCQs in the next video, and every video will be having the 5 MCQs, alright. We will be making a long series of infectious disease and all the topics of the past medicine, alright. Bye bye, have a good day.